Hi, Don here with Podiatry Practice Mastery. This is going to be a special episode of a lecture that I gave to the Endocrinology Fellows at UMass. A podiatrist locally here in Worcester and in Westboro. And I'm going to give you a little podiatry update of some of the current treatments and advanced therapies in treating the diabetic foot. So I'm happy because each year, or I do this every couple of years, usually every 2 years as the fellows change, and sometimes some are interested in the diabetes portion of endocrinology, and sometimes there's not as much interest. So I'm happy to field any questions. I know you might see more in the inpatient, more of the severe cases, and not so much in the outpatient clinic. But I know a lot of the endocrinologists at UMass, and we kind of work as a team. Many times the patients will come in and I'll ask them, are you on something for neuropathy? And many times the endocrinologist will give them gabapentin, Lyrica, Cymbalta. They'll try certain things for them. So we kind of have this approach going back and forth. And we take care of the high-risk feet. So we're going to go over that. But since I do this talk so often, I like to go over some new things first because I always think that's kind of interesting. But the objectives here are to learn how to diagnose an at-risk diabetic foot, determine the risk factors leading to diabetic foot infections, understand current treatments, and then understand the incidence and economic impact of diabetic feet. First of all, starting with some of the new treatments, this is one new treatment. Have any of you heard, Alexandria or Dilip, about Cenza? Have you guys heard of that before?
No, actually.
Okay, so
actually, is it capsaicin? So maybe capsaicin, but I don't know about this one.
So you've heard about capsaicin. So if you would get, let's say that you've heard of topical capsaicin that patients try when they have neuropathy. You tell them to go to CVS and they buy the topical capsaicin. You tell them to try to buy maybe like a BioFreeze, or you might have them try Icy Hot or anything like that to get rid of their diabetic neuropathy type of feeling. I think you're already doing that. But this is a topical capsaicin that is much, much stronger than any other capsaicin. So going from less than maybe 1% to 8% capsaicin, it's very strong, and it's actually considered a nerve destruction when we put it on their feet. So the goal of the capsaicin, if you look here, there are little plastic, I call it a plastic sticker without a sticker. It has a piece of plastic, and inside of it, it's impregnated with capsaicin in a kind of a micro particle format. You put it on the foot and you wrap it with Coban, and the patient stays in my treatment chair for 30 minutes while it's basically burning the nerves. It's kind of like giving them a sunburn on their feet. That's what we say. And this is a fairly new treatment that's come out that's offered in the office, and that's why I asked Chris before if you were doing this in the office, because I know many times the endocrinologist, you are at the front line of the oral therapies, and it would make sense to me maybe in the future you might consider doing this as a way of getting away from medications. So this is a way to reduce the oral medications that patients are on for diabetic peripheral neuropathy. It desensitizes the pain receptors. So we put this on, and after 30 minutes, my staff checks them at 15 minutes. We take it off at 30 minutes, and then they feel like they have a sunburn. Some of the side effects I've seen, I have some patients, it was summertime, and they went out to mow their lawn afterwards. And it's kind of like mowing your lawn on your feet with a sunburn on your feet. You know, it's going to hurt a little bit. There are some instances where patients can have some lower blood pressure. I had one patient like that, but the majority, it's pretty safe. When you're putting it on, if you do decide to put it on, you have to be careful, not so much putting it on, but when you take it off, because it kind of goes up into the air. So when I take it off, I roll it inward and I put it inside of my glove, and then there's like this gel that you put on there that takes out any of the excess, so it stops the burning. And the thought is the epidermal nerve fibers, it kind of burns them or gives them a sunburn so that they kind of calm down for the 3-month period. Then you put it on. So it's something that needs to be done every 3 months, okay? And you usually need to do 3 to 4 sessions initially to see benefit. Now, that's a lot of sessions. That's a lot of visits to the podiatrists, but it is having some good success, especially with a lot of these patients that might be on a lot of medications for the gabapentin or for the neuropathy, and you're wanting to change that, getting them off of some medications that could be harmful for them. There's really no other side effects besides that. So it's something you might want to think about, you might be considering for the future in your practice, something called Cenza. Any questions on that? Okay. Another thing that I'm just kind of throwing out here, this is kind of a new technology that's been used in wound care. I don't know if have you ever heard of Shockwave treatment before? Any of you? You can just say yes if you have. Maybe you haven't. Okay. So Shockwave, you've heard of lithotripsy to break up kidney stones, right? I think you've heard of that.
Yes.
So
yep.
when you take, this is kind of like a handheld lithotripsy device. It uses sound waves, and to areas that have poor blood flow, like on the diabetic foot, it's something that can be used to stimulate healing in diabetic ulcers. A lot of these ulcers, they don't have the best circulation. We're working in tandem with vascular surgery, and this is a newer treatment that we're doing in the office. I don't do as much of it for wound care as I do for musculoskeletal, but I thought it was something that would be pertinent for our conversation today, especially with you as endocrinologists, something that you might see, a way to help heal wounds, maybe in a foot that you can't maybe get as much vascular flow to. So for example, after doing a transmetatarsal amputation, if there's poor wound healing, you could do a few sessions of the Shockwave, and what it does is it injures the tissue to help it to heal faster. And it works very good on soft tissue areas. So it's something to consider, just something that's new I thought might be interesting for you to know. Another thing that might be interesting is something called balance braces. And we know that many of the patients that we see, they have balance issues due to diabetic neuropathy. You've probably seen the patient that comes in and they stomp their feet so they can feel where they're at. And because of that severity of the neuropathy, they have more risk of falls. They're more risk of being unstable. And these are little devices. They look like they're actually an AFO, an ankle foot orthotic, that goes on the back of the foot, and it has two little straps here. And these help with proprioception. So it helps patients to recognize where they are at when they are walking. Because they feel the movement, they feel the pressure on the lower leg, they might not notice anything on the bottom of the foot, but they're going to feel this on the back of the leg. And these are very useful for patients. In a patient that would be a good candidate for one of these would be a patient that is already using a cane or using a walker. It does not substitute that, but we know that falls are something that we want to prevent, and these are called fall prevention braces or balance braces for patients. And very, very commonly we use this for muscular weaknesses. We might use this for a drop foot, but specific to our conversation today, for patients that have neuropathy and feel that they are unstable on their feet, or their loved ones might say that you can tell these patients because they tend to have to hold on to the walls when they're walking. They tend to have a difficult getting up and having the strength and kind of going through the doorway. When they turn, they kind of lose their balance. So these are the type of patients that we would consider using for the balance braces. Have you heard of, I'm sure you have, but I don't know how you're using it yet. You've heard of remote patient monitoring. Have you heard of, do you have any, it would be similar, you probably heard heart patients, they have these monitors on their heart, right? So it remotes in. This is going into every single area. You are doing remote patient monitoring, I think, with blood sugar readings, where you can get their readings at home in the office. Is that correct? You can kind of monitor them now as endocrinologists? Yeah? No?
Yeah, in conjunction. Yeah, I think in conjunction with like the CGMs, we can do that.
Yeah.
But I think that cardiology definitely has like systems, and I think the other ones too. Yeah.
Yeah. So we have a system now, and the reason I'm saying this because what we're seeing is there's one provider locally. I think it's not Reliant, but what Reliant, like they're kind of that insurance. What they're doing now, and this is kind of unique, is they're sending me a form and having me fill out the form so that the patients can get this plate, okay? And so I think the insurances are doing it as a risk prevention tool, but I also think they get paid for it, for the remote patient monitoring. The insurance does. I've never prescribed one, but you might be asked this in the future to sign off on this. So what this is basically a plastic foam plate that patients stand on every morning, and it is able to determine if there are high pressure areas or areas that are hot. And that would be an indicator, kind of a pre-indicator of a diabetic ulcer or a hot spot on their foot. There are multiple ways that this is done. One way is an ingenious diabetic sock. It's a sock that they put on, and for some reason it's able to track. It has these little sensors inside, and you can still wash the sock. It's kind of a cool thing. They have socks. They have diabetic insoles as well. So the actual diabetic, those insoles that go in the shoe, they have sensors in some of them. And then they have this pressure mat. So as we go along, we're gonna see many other types of preventative devices in these remote patient monitoring for our patients. So you can see this example right here under the first med head in the medial arch. You could see an area of red, and what I get from these companies is they fax actually something over when they notice a change. They fax something, or they send something to the patient via email, say, hey, go get your foot checked. The patient shows up in my office, and they also send something to me via fax, sharing that patient that was being monitored has this. Now, the biggest drawback to this is actually having patients stand on these plates every single day. Like, it's hard to get patients to be compliant to do anything, let alone stand on a mat every morning. But it's a neat idea, and I think it is something that is going to be the future for us. And then finally, 3D printing. I think this is also something that is here. And this is an example of a 3D printer that can be used in a podiatry office. And there are different things that can be made. This is an orthotic. This is like a pediatric orthotic, an orthotic that's a little bit higher up, and these are AFOs. So similar to the other AFO I showed you, the future is going to have custom printed braces and custom printed orthotics. We're not to that level yet, because to print an orthotic takes about 5 hours. I think it's 5. If it's not, I think it's 5 hours per pair, or maybe even per device. So it just takes a long time. So what would happen is you would do it, and we already do the 3D scan. We have a 3D scanner. We scan their foot, and we put in a prescription. We send it to a lab. That's how it's done currently, and they fabricate it. But I think in the future we're going to scan their feet. We're going to hit print, and they're going to print out maybe a custom shoe or a custom orthotic. I just think these are some interesting things that are coming up in the future that you might see that might affect you as endocrinologists. Okay, now we're going to get into the part about at-risk feet, and this is the part I think it'd be fun for us to have some interaction. And just so I know, the hard stop here is you want to be done at 2. Is that correct for all of you?
Yep, I think like 2. Yep.
Okay, good. So let's look at this patient here. This is one of my patients. You can see, I'm sure you've seen feet like this. This is the second toe. That's a little bit red. Okay, there's a little bit of something going on right here. It looks more swollen at the tip. If you want to, I don't know. I see Connor. I didn't say hi to Connor. Connor, what do you think is going on in this second toe here? Any idea? Ingrown toenail? Or maybe you can't talk. I don't know. Or Dilip, what do you think's happened in this second toe? Any idea?
Yeah, I mean, it's a limited view. What I can see, is it the nail is like on the missing? Is it like?
Yep. The nail's missing. Yep. How about the color of the toe? Does that look normal?
No, it's quite really discolored and swollen, inflamed.
Yeah. So this could be a couple of things. You could consider some differentials would be a fracture of the toe. Another differential could be an infection.
Yes, of course.
And I think the infection would be the better option, I think, of this, because there is a little bit of a sore you can see here at the tip that had happened. And very commonly, these patients, they get little bone infections to the distal tip of the toe. And really, if you try to give these patients 6 to 8 week of IV antibiotics, it doesn't work too well, because many times they don't have the best circulation. So if you give them IV antibiotics, to get it, bone penetration is a challenge, especially if there's bony erosion on the MRI. Now, this is something as being on the endocrinology service and you're inpatient, you are seeing this probably every week. I would assume you're seeing these things. They have, positive bony erosions at the tip, positive osteomyelitis. So the standard of care for this is usually just an amputation of the toe. Even though it seems a little severe, if there is bony changes and there's an open ulcer, we're gonna amputate that. There are some newer antibiotics that you can try to heal it with antibiotics using infectious disease and things like that. But if there is an actual open draining wound and it has a positive probe to bone, many times we're just taking the toe. The problem with taking the toe is that everything's going to drift over and you're going to be at risk of developing other ulcers. And that's the biggest challenge. One of the biggest risk factors is when you have an ulceration or when you have an amputation, the risk of getting a second amputation is very, very high for these types of patients. One kind of problem leads to the other. This is another example of a patient. This is the IPJ of the hallux. And you can see here's an open wound. You see a little bit of white around the edge. That white is maceration. And here you can see another area where it's red. It's turned from being just white. It looks kind of soupy inside. That's a fibrotic wound base. And this patient, you can see the x-ray. Here's the cortical margin right here, and you can see it's kind of broken away here, the cortex here. So, and it's kind of broken away down here, and this would be a positive sign for osteomyelitis of that toe. And this would be one, we don't mind seeing them when they look like this, but when they get really swollen and soupy and they don't get better with antibiotics that we give them, many times these types of patients, we have to go in there and amputate this, or at least take the distal phalanx here for this type of a patient. So this is something that you see in UMass all the time on a very frequent, too frequent of a basis, unfortunately. And you're consulted for these patients that usually have very high blood sugars, they're uncontrolled, and they're not the best surgical candidate as well, because we're concerned about dehiscence of these wounds if they have really high A1Cs afterwards. Okay, this is an example of a patient that you can see this little area right here and this little area right here. This is a high-risk patient. Okay, this is these right here lead to this. So let me explain what's happening here. In the picture on the left, you can see a patient with a big toe, and he has this little red spot. You guys know what that is? Any idea what that red spot is there?
Is it just like a pressure point that started to ulcerate you?
Correct, starting to ulcerate. That's exactly what it is, Alexandra. It's a pre-ulcerative callus. So you're going to be seeing patients, let's say you do diabetes, and I would recommend at least once a year taking their socks off. I don't think the endocrinologists do it every visit, but just take a look and kind of know what you're looking at. And if someone has, I want to show you the difference. Like, okay, this here, the picture on the right, on the fifth metatarsal head, this is just a callus. Okay, but if a callus isn't treated, or if a patient loses the fat to the front of the foot, it can cause an area of red, and that's a pre-ulcerative callus. So a callus that has probably a little bit of a wound underneath there, and it's caused by pressure. This is different than a pressure sore. Okay, a pressure sore typically is on the back of the heel when people are in bed too much. This is caused by walking with lack of fat pad on the bottom, and there are a couple ways we can treat this. I usually see these patients back periodically. We trim down the callus. Another thing that we do is we make a high contouring orthotic. So by doing an orthotic, we can take the pressure from the first metatarsal head and push it into the arch. And so we have a special way of doing that with an orthotic or a diabetic shoe as well. There are diabetic shoes as well that can offload that area. We want to avoid this because if this isn't treated, and many times patients don't feel this as painful because they have neuropathy. They are not feeling this. This doesn't hurt them. They continue to walk on it, and it just ulcerates and goes deeper and deeper in their foot. And eventually, this will get infected and will lead to an amputation. This is what we're trying to avoid. Once you take off the big toe, you can see there is a pressure distribution next door. It's called a transfer callus. So it's transferred from the first metatarsal head to the second metatarsal head. And the reason it goes to the second metatarsal head is because of the pressure. You don't have the big toe taking the pressure when you're walking, so all the pressure goes under this aspect of the foot. You can see what's going to happen. This is going to ulcerate, and then they're going to lose that toe, and then so on and so forth down the road. And that's what we don't want to happen. We don't want one toe to amputate, then the other one, then the other one. That's not very good medicine. So we try to avoid this. This person would need to be in a diabetic shoe. They would need to have what we call an amputation fill. So it's like a fake toe that you put in there, and you would try to offload this. But this is a high-risk diabetic foot. This patient probably doesn't have the best circulation. This patient probably has neuropathy, and this patient could very easily lose their leg. Okay. Any questions? You guys have any questions? Like, oh, I saw this in the clinic. I don't know what to do. Anything that, okay, if you guys can think, you can just type it in the chat box if you have any questions, okay? I just want to make sure I answer because this is the time we have, okay? So you have any things, oh, I was really thinking about these things. Okay, this is another example of a patient of mine. You can see here at the tip of the second and third toe, and then the third toe here, second and third on the left, and the third, actually on the right, and then on the left, the third. What are those things at the tip? This is something real simple. What are those things at the tip?
Ischemic ulcer, like.
You said an ulcer, Dilip?
Ischemic, like, is a tip.
Yeah, this is a callus. So this is a patient that has a callus to the tip, and all calluses they are caused by pressure. So when you have a curved toe called a hammer toe, when you're walking on a surface, it's going to hit it, and it's over time, these toes don't straighten like yours, right? They're rigid, and then that pressure causes a callus at the tip. If this callus isn't trimmed down every couple of months, this callus is going to lead to an ulcer. Okay, that's why insurance covers for callus trimming. It's not because they want everyone to come in for callus trimming. It's because calluses always lead to ulcers. Okay, I'm not saying that every callus is going to ulcerate. What I'm saying is that all our ulcers are usually preceded by a callus or a poor-fitting shoe. Okay, and these may or may not be painful. We're not going to straighten all the hammer toes on these patients. We're just going to trim down the calluses, make sure they're in appropriate shoes, and make sure they don't ulcerate. Okay, but this is a fire waiting to happen with this type of a patient. And a lot of times what they do is they open up and then they close. They open up and then they close, and we're kind of dealing with these diabetic feet. And another thing I just want to remind you is that when patients have diabetes and neuropathy, they always, especially females, they always say, you know, doctor, I've always been a size 7. Like they've been a size, like they're 95 and they've been a size 7 since they're, 15. And most of these patients, as they get older, their feet get bigger. But they don't think they're a bigger size, but they squish their feet into these smaller shoes, and that's a big reason for developing ulcers, blisters, and amputations, because the patients think that the shoe is big enough, but it's really not. And the reason they think it's big enough is when they have neuropathy, if something feels like it's fit, it's actually too small, because they don't have feeling. They can't feel if it's the right size or not. So I would even recommend looking at their shoes. If you ever take out the liner. So the liner is the thing that's inside of the shoe. This is a test that I do every single day. So I take their shoe, I take out the liner, and I look at where their indentation of their big toe is, or any of the other toes. And they have to have a finger's breadth at the front. If their toes are going right to the tip of the liner, that liner is too small and can be a big cause of callusing and can be a big cause of ulceration. And you can't just say, oh, I'm a size 7, because a 7 in a Skechers is different in a New Balance and different in an Asics type of a shoe. So you can't just do that for everyone. Okay, here's a couple of other patients of mine. This one on the right, this was an ulcer that is kind of healing, and it's taking its time to heal. There's a dry eschar on top of it. Most likely some osteo on that's going to need to be removed. Okay, these are high risk feet. Another patient, they also have a swelling. You can see the swelling also makes it a challenge. This is another patient that has a pre-ulcerative callus on the top of the right third toe. You can see the blood underneath it. This is going to be a challenge. Most likely there's an open wound underneath there. And this is another patient that's had a previous ulcer on the bottom of the heel, have a really bad callus down there, and this patient needs to come in once a month to have that trimmed down because it hurts them so much. So these are other examples of high-risk feet that you are going to be seeing in the clinic. Here's an example of a patient. Very commonly our patients are older. They don't have the best skin integrity, and if they bump their leg on something, they can easily get a cellulitis on the lower leg. And cellulitis and cuts and ulcers on the lower leg can be a challenge to heal. Takes a long time for them to heal, and this needs to be treated. Now this is one of my favorite patients. He was very high risk. You can see here, this is the before on the right, and the after here on the left. You see what happened. He has these little toe covers on the first and second toes. Those are to protect it from callousing. He has the first 3 toes, and he's missing the whole side of his foot. He'd had a previous, you can see the incision right here, he's had a previous incision and drainage, and now he has another ulcer underneath the 4th met head. And that's what I mean by once someone has a surgery or an amputation, they're very likely to have another one in the future. And we did everything we could to try to save this foot, and unfortunately he passed away. But this was a challenging case because that went down to bone, and then a portion of it needed to be removed along with a skin graft. Okay, this is a high risk foot. This patient didn't have any feeling. Very, very nice gentleman. So I'm going to go over what can be done on your end of things for a diabetic foot exam. The diabetic foot, we've talked a little bit about the risk factors. Now I'm going to kind of teach you, kind of walk you through how to do a diabetic foot exam. Now I would be happy to come there to your clinic if you ever want me to come and show you this. Or you could actually come and visit me if you ever want to take a half day and just come and visit me in my clinic to see this. But we look at the skin, we look at the nervous system, the bony deformities, circulation, and then we look at shoe gear. The way I do it in my office is I do a diabetic, so for a lot of the what we call routine patients, I see routine patients just on Friday mornings. That's kind of the way we do it. We just kind of put them all at the same time. And routine would mean diabetic patients with neuropathy and usually PVD. And they're patients that are high risk for problems. Now, if someone has an infection, cellulitis, they can come in any day. They don't have to wait for that time, or ulcer or things like that. But the standard diabetic patients, I see them every 3 months or every 60 to 90 days. And I do routine nail care. So I'll trim the nails, trim the calluses, because they're at risk. Then once a year, I just use their birthday as the way to remember when to do this. So if their birthday is in January, either on December, January, or February, when I see them back, I do a comprehensive diabetic foot exam, and I send that to their primary care and their endocrinologist. Because otherwise I'm telling you as an endocrinologist, I trim the nail, trim the nail, trim the nail, whereas I don't really do an examination. So once a year, I'll do a diabetic foot or a comprehensive diabetic foot exam. I'm looking at them every 3 months, but I do a little bit more of an involved thing. Okay. What do we look at in terms of skin? I've showed you a few things before. I showed you you want to look for blood, you want to look for calluses, you want to document those things. This is an example of a patient on the back of the heel. He had a hard skin, callous skin, and he had these heel fissures. Now, when he started to use a moistening agent on this, a cream, the things just opened up because what was keeping them closed was the dry skin. And this was something that took a long time to heal. He specifically had a lot of swelling in his leg, and I find that patients with swelling, the ulcers become a portal of drainage. So we had to do a lot of intense compression on this to get this to heal. Another area is treating any fungal infection between the toes. I think it's very important for us to look between the toes to see if there are any cuts, see if there's any dampness, if there's any issues, and then treat any of the fungus with a topical antifungal. I tend not to use gels or creams between the toes because it can macerate too much. Many times I'm going to use a antifungal gel or lamb's wool or things like that between the toes. Example of a couple of calluses. Calluses usually are trimmed down unless you know, because that could create a blood underneath there, which would lead to an ulcer. You can also offload them, like I said before, with diabetic shoes and with orthotics. This is an example of some interdigital corns, so we call them soft corns. So what's happening is this part of the bone is hitting against this part, and they create this big, this is between the fourth and the fifth toes right here. And these big calluses between there, they need to be trimmed out. There's a little procedure that can be done. You can see here where you take out the head of that bone, or you can shave down a portion of the bone so that doesn't keep coming back. Also regarding the skin, there are a couple of treatments you can do for ingrown toenails. If there is an infected ingrown toenail, you have to remove the painful ingrown toenail. This is an example where I put a chemical down there to kill the roots, called a matrixectomy. There are some other treatments where you put like a resin to help straighten out the ingrown toenail. Ulcers once again should be debrided. They should be treated. This is an example of an ulcer that was healed on a Charcot foot. You can see a very wide foot. This is an example of an infection. This patient needed an incision and drainage. Luckily, she was able to save her toe, but she did have a cellulitis that this needs to be opened up urgently. You can't just give them IV antibiotics. Nerves, like we talked about, we want to do the Sims-Weinstein. I'm sure you all test the different areas on the foot. You want to test, I usually do first, third, and fifth digits, met heads, a couple here, and then on the top of the foot. I have them close their eyes because the patients try to cheat because they don't want to fail the test. Then I also do the tuning fork where I tap it and I apply to the tip of the great toe. And I ask them, you know, tell me when you can't feel the vibration. And I document that. We talked about some of these foot deformities before. I think foot deformities combined with neuropathy are the secret sauce for developing ulcers. If patients just have foot deformities and no neuropathy, many times they'll feel it. But if they have neuropathy, they're not going to feel these things. So there could be a foot deformity like a hammer toe. Here's hammer toes. Here's where you fix the hammer toes. There's something called Charcot. It's obvious, but I'm not going to assume anything. Have you ever heard of Charcot deformity in the foot? Dilip?
Yep, I think we have.
Yeah.
Yes.
Okay. You guys see all the Charcot because you guys see all the very difficult feet at UMass. Okay, so you're going to see these feet that are blown up. The way I explain it to patients is that they break their foot and they don't have feeling, so they keep walking on it and it continues to break. Okay, that's how I simply explain it to them. And the foot kind of collapses right here, and then we have to treat any of the ulcers by removing the bony deformity. So a couple ways of doing that would be keeping them off. The most common way is, first of all, not treating it as an infection. So if you can learn one thing here is that if you have a patient with a red hot swollen foot, right, and then they get off the foot and the redness goes down, and then they put their foot down and it gets red hot and swollen, many times that is Charcot, okay? And it's very commonly mistaken as a cellulitis, right? A lot of times patients are in the hospital for cellulitis, they put them on IV antibiotics, the cellulitis goes down, they think it's cellulitis, but the reason it goes down is because they're off their foot, okay? Then when they get then they leave on oral and their foot goes down and the redness comes back. Well, the redness isn't from the cellulitis; it's from the Charcot foot. It looks very similar. And where it gets really confusing is when they have redness along with an ulcer somewhere, and so it's hard to tell if it's Charcot or not. So you maybe want to consult podiatry for that. If it is Charcot, there's no need for an antibiotic. You need to put them non-weight bearing or in a Charcot restraining orthotic walker, which is this boot right here, which kind of looks like a helmet for your foot. It has these little straps around there, and it's made custom for their foot. And as the swelling goes down, you have to add more padding, and that helps it to heal by taking the pressure off the foot. Here's another patellar tendon bearing brace. These can be either done at Hanger Labs, which is a podorthist, or local podiatrists can do this along with an offloading scooter. These take forever to get better. Okay, a normal break takes 6 to 8 weeks. These usually take about 6 months. okay, for these patients. Something to consider vascular-wise, if there is increased blood flow. Many of these patients with Charcot have good blood flow, and that's one of the reasons when they break their foot, there's a lot of blood flow and it just keeps breaking. We work very closely with vascular surgeons. In our office, we do have a Doppler that we can do in the office. This isn't a venous duplex. This is a Doppler just to see how the pulses are, if they have palpable monophasic, biphasic pulses. We also look at the ABIs. We do AVIs and PVRs in our office, but many times we'll send them to the vascular lab, and then MRA, which is an arterial evaluation, like MRI, but of the arteries. And there are a lot of different vascular procedures that can be done, many of them minimally invasive. The best one, though, that I want to share with you, or the worst, I don't know if it's the best or worst, is a patient that comes in with an ingrown toenail, and many times this might not be just an ingrown toenail. It could be poor circulation. So I've had, unfortunately, a patient of mine that came in for pain to an ingrown toenail. I took out the ingrown toenail, and that wasn't the problem, and they ended up having an amputation. So something I never want to happen again. So you have to be careful if it's just an ingrown toenail or if it really is poor circulation of the patient. So usually there's no pulses, and if there's a raging infection, you have to remove the edge anyway. But if there's no raging infection, it might be circulatory, so you might want to send them for a vascular evaluation. Shoe gear considerations. Once I talked a little bit about the shoe fit, recommending a wider shoe, insoles, orthotics. You are going to be asked probably more than anyone to sign off on this paperwork for diabetic shoes. Do you have any questions on this diabetic shoe paperwork that you have to sign?
I've actually not had to do it just before. So is it something that the patient comes to us with, or is it something that we find the paperwork to give to them, or how does that work?
Yeah, the process is the following. So the process is the patients need to have a prescription for the diabetic shoes, which a podiatrist,
okay.
So a podiatrist can give it to them, their primary care can give it to them, endocrinologist can give them. They get the prescription. Then they go to a diabetic shoe provider, okay? And that's someone that dispenses diabetic shoes through their insurance. There's only a couple of shows in town. Like the only one like nearby is in Marlborough. It's called Beauvier. They're a diabetic shoe provider, so they would go there. Then when they go there, they pick out the shoe, and then this is the hard part. Then Beauvier sends usually either the primary care or the endocrinologist. They have to send them something to verify that they have diabetes and a risk factor. So they have to have diabetes and PVD, diabetes, so you're going to sign that paperwork, or the primary care will. They're going to send me the prescription of like the diabetic shoe, and then many times they're going to ask for my note, because in the note it has to be documented they have that risk factor. So if I say they have PVD, your note has to say PVD. If it says foot deformity, I have to have foot deformity in my note or your note, because otherwise what happens is they don't get paid. And this is all needs to happen within like 90 days. And so this is the whole problem why we stopped doing it, because it's a rigmarole to get these shoes covered, and if you don't get the paperwork in time, they get the shoe, but the patient doesn't get paid. So it's kind of a pain, and there's no one that does it locally, because like the juice isn't worth the squeeze. Meaning it just, maybe they get reimbursed $300 and maybe it costs for $100 or $150. So like it's not worth it for the headaches, right? For the headaches of doing it. So, but just something to be aware of depending on where you go and practice diabetic shoes. These are, I talked about before, these are all shoe errors. These were shoes, like tight shoes here, tight shoe here, tight shoe here, tight shoe here. These are all tight shoe things that happen from shoes that were inappropriate. So you really have to be careful in your patients. I would recommend having you take their shoes off or have someone take their shoes off. Diabetic foot ulcers, the incidence annually is 1 to 4% of all of our diabetic patients. The lifetime risk, about a quarter of them are going to get an ulcer at some time. Now 15% of ulcers result in amputation. Okay, that's the challenge. So 15% of diabetic ulcers result in amputation. It's very costly. And 85% of amputations in patients with diabetes are preceded by an ulcer. That's what I meant before when I was saying that. So like a callus precedes an ulcer, and an ulcer precedes an amputation. That's how it goes. So we want to prevent the calluses, and we want to heal the ulcers as quick as possible. And peripheral neuropathy is the major contributing factor to diabetic ulcers. Okay, so I'm going to stop right now. I have more things, but I don't want to go. I want to make sure I answer some of your questions or any things that you have to ask me in the last 5 minutes here. Do you guys see these types of feet? Do you have any questions about when you see them, or do you just kind of defer to podiatry?
Yeah, no, this is super helpful. Thank you so much. The question I had was about the prescription for the footwear too, and like also, I think a lot of the folks thankfully have had established like so far that I've seen, which has been helpful at least. But
they have care, they have podiatry care. Okay. Yep. And you guys have a different demographic there at UMass. You see all of the really kind of difficult patients there. You're tending to see the ones that are going to end up leading to amputation. They're going to need vascular. They're going to need infectious disease. They're going to need podiatry to care for them. I tend to see the ones in the outpatient after they've kind of come down from that critical limb ischemia or critical limb infection. Then they're coming in, and we're trying to prevent other things from happening. But I think it's a team approach. I have a good relationship. I think you have a great diabetes center there, so it's very good. Okay. Well, I hope this was beneficial. I wish you all the best. If I can be of any assistance, just let me know, and hope this was beneficial. And I'll probably do it in a couple more years. Okay.
Awesome. Thank you so much.
Okay. Have a good one. Bye bye.
Bye bye.